The key thing when determining correct electrode placement is to ask the patient how and where the pain presents. You need to determine, are there two locations of pain? Is there a single location of pain? That's going to determine whether we're using the B-set electrodes for two locations of pain or the E-set electrodes for a single location of pain on the extremities, or the U-set electrodes for a single location of pain in the mid-torso part of the body. So in the example for low back pain, we're going to start with bilateral lumbar pain. So I'm going to ask the patient, we know the diagnosis ahead of time, can you point to the center of where it hurts? Here. And do you also have pain on this side here? Okay. So these are the locations that we want to place the electrodes because this is exactly where the pain is presenting. So the electrode peels off the plastic liner. We place one electrode directly over one location of pain. We place the second electrode directly over the second location of pain. And we orient the wires typically down so the weight of the connector does not pull on the electrode. The patient feels nothing on the skin in between the electrodes. They only feel the sensation in the hemisphere beneath each of these two electrodes. The effect of the electrical field is not just beneath each electrode, it's a 3-inch diameter hemisphere beneath each electrode. So this is typical for bilateral lumbar pain. If the patient has a radiculopathy, and let's say the diagnosis is a herniated disc at L5, and it's a right side radiculopathy, one electrode is placed over the origin of the pain, and we actually want to be about 1/2 inch to the right, so we're capturing where the pain signals are coming off of the spine. So instead of being right over the spine, we might be 1/2 inch to the right if this is the origin of the pain. And then let's say the pain first presents in the lumbar area or the buttock area. We want to place the second electrode directly over the most proximal location that the pain presents relative to the origin. We never place this electrode distally, even if the patient feels pain radiating through their knee down to their foot. So if this was the primary, if this was the first location that the patient felt pain, then we would place this electrode right in this location, if that's the most proximal location, and that's how we would treat a radiculopathy. If a patient has pain centered directly over a disc, let's say this is where the pain presents, we're going to place that one electrode right over the center of that pain site. Now, where do we place the second electrode? We want to put it over a bony prominence typically because that's a comfortable location. And on the spine, it's more comfortable to take stimulation lower, L5, S1, S2, as opposed to higher. So we would place this electrode approximately here, and we want to leave 1 inch of spacing between the two electrodes. 1 inch is the minimum spacing between electrodes. Very important, the electrodes can never touch each other. If the electrodes touch, the patient will receive a burn in 5 seconds. It'll be warm, hot youch. So 1 inch is the minimum spacing on the back, 1/2 inch is the minimum spacing on the extremities. So this would be for a single location of pain here. The second electrode is placed in this location down here. Okay, let's do unilateral low back pain. Let's say the pain presents just to the right side of the spine in this single location. So again, you're asking the patient to point to the center of where the pain is. We're presuming that's the center of the location of pain. We place this electrode. Now, the bony prominence location, we want to have 1 inch of spacing. So we're going to take this electrode and we're going to move lower. So we're right over the spine close to the sacrum. It's a very comfortable place to take stimulation. We have 1 inch of spacing, and that's how we would place the electrodes for a single location of pain in the lumbar area on the back. For SI joint pain, the electrodes can be placed bilaterally over the SI joint. But if the pain is right over the sacrum, we can place one over the sacrum, and one can be an inch apart if there's a little more pain to the right side, or if there's over the sacrum and there's a little bit more pain, we can place the second electrode to the left side of the spine, or like I said, we can do a bilateral placement. This is an excellent treatment for SI joint pain. For the mid-torso part of the body, for single locations of pain, we use the U set. U is for unilateral pain. The U set is comprised of a 2-inch round pain site electrode paired with a very large dispersive pad, 8 inches by 5 inches. So if the patient has hip pain, they have to point to the center of where the pain is. Let's say this is the location. We're going to place this electrode right over the location that the pain presents on the hip, the single location of pain. And then this dispersive pad is always going to be placed across the lumbar area of the body. It might start at S2 and go up from there. So this placement, this is not just a bony prominence, it's just a convenient and very comfortable place to receive stimulation. So we can place this electrode just like this. Okay, and so this would be a typical placement for a hip issue. If you had a patient with an oblique strain, depending upon wherever that pain site presents, the patient has to point to the center of where it is. You're going to place that electrode right out over the location. If the patient has a rib contusion or a rib fracture, you can treat right over a rib to treat pain in that location. For hamstring strains or hamstring related pain, if it's a single location of pain, the 2-inch round electrode goes right over wherever that pain site is. So if this is the center of where the pain site is, then this is where the electrode is going to be placed. If it's a high hamstring tendon issue and pain's presenting here, then we're placing this directly on the skin, not over the shorts, directly over the location where the pain presents. So again, you're asking the patient how and where the pain presents, you're identifying the correct location, we're placing the 2-inch round electrode directly over the pain site. This is the comfortable location for the dispersive pad when we use the U set. For quadriceps strains or other quadriceps related pain in the belly of the quadriceps, we still have that 5-inch by 8-inch dispersive pad across the lower lumbar area. That's the comfortable location for that pad. And this 2-inch round pad is right over the belly of the quadriceps wherever that painful location presents. So that's for quadricep pain. For groin pain or a groin strain, the 5-inch by 8-inch dispersive pad is in the same location. It's horizontally across the lumbar area, and the 2-inch round pad can be placed either below or above wherever that groin pain is presenting. So you would use the U set again for groin-related pain. The B set, in addition to treating 2 distinct locations of pain, can also be used to treat a large area of pain. So if these 2 electrodes are placed 1 inch apart from each other, we can capture a 6-inch by 3-inch volume of tissue, or 6-inch by 3-inch volume of tissue. So if you have a patient and the pain is presenting over a large area of the lumbar area, starting in the lumbar area and moving up toward the thoracic area, if we place these electrodes 1 inch apart from one another, let's say the pain presents here, kind of through this whole region up through here, and you place these 1 inch apart like this, essentially you're going to treat this entire volume of tissue on this part of the back. So this could apply to the hamstring if the pain's over a broad area of the hamstring, or another part of the body where pain presents over a broad area. This is the way to treat a broader area of the pain. Use the two 2-inch diameter round electrodes 1 inch apart. For the knee, we can treat using either the B set or the E set single location of pain electrodes. So again, we want to ask the patient how and where the pain presents. Are there 2 locations of pain? Even if there's a primary location and a secondary location, we're going to use the B set. Is there a single location of pain? We're going to use the E set. So if a patient, for example, has chronic OA knee pain, and maybe they've got grade 3 or grade 4 osteoarthritis, there's pain through the entire joint, it's not point specific, then a good way to treat that type of pain is to place the electrodes, one on the medial aspect or joint line of the knee, and one on the lateral joint line of the knee. And this way we're getting an electrical field, and the hemispheres will intersect internally, and we can treat the entire knee. If the pain is from, say, you had an ACL repair, and the pain tends to be a little bit more toward the anterior of the knee, and perhaps the patellar tendon was used or a hamstring tendon was used, and the pain might present a little bit more to the medial side, but sometimes in an ACL it might feel like it's throughout the entire anterior of the knee. We could place one electrode closer to the anterior and the other one closer to the anterior of the knee, so they're not as far back as in the other example, and there's only ½ an inch of spacing here between the electrodes, and if the patellar tendon was used, you can be right on either side of the incision here, and this is a good way to treat perhaps pain from a post-op ACL. For pain from a patellar tendinopathy, that typically presents right where the patellar tendon is. Again, you have to ask your patient to point to the center of where the pain is. If that's the location, we're going to place this small electrode directly over the center of where it hurts. The larger electrode, the bony prominence comfortable location for it, is we're going to place it on the lateral aspect of the knee. We're going to be about 2/3 or 3/4 of the way up the lateral side of the patella. We're going to touch that and run this vertically down the lateral side of the knee. The nuance of this placement is we do not want this electrode to touch the distal end of the quadriceps, because remember, muscle's held in tension. So if this is held in tension, it's not going to be uncomfortable, but it may act like a distraction, and the patient may not want to go up as high as if this were in a comfortable location to receive stimulation. We don't want to limit the patient in how high they go up by what they feel under the dispersive pad. We want them to only be limited in what they can tolerate by what they feel under the pain site electrode. And in this case, where the pain is, it's over the patellar tendon. The other thing is we don't want this dispersive electrode on the lateral side of the knee to be more posterior, because back here, if the electrode covers over the peroneal nerve, we can stimulate the peroneal nerve, and the stimulation that one feels along that nerve, again, may act like a distraction. So we don't want to be more posterior with this dispersive electrode. Some people ask, well, why not place it over the tibial tuberosity? Just not as comfortable to take stimulation there. So stay off the distal end of the quadriceps, stay away from the peroneal nerve. This is a good location. For pain on the medial side of the knee, like an MCL sprain or a bursitis or OA or a meniscal issue, let's say the pain presents right here. The patient points to the center of where it hurts. We place the electrode over the pain site. Now the ideal bony prominence comfortable location for the dispersive pad is we're going to touch the lateral aspect of the patella. Again, we're about 3/4 of the way up the patella on the lateral side, and we angle it across the anterior of the knee, across the patellar tendon. this is the most comfortable place to take stimulation in the knee. So unlike the patellar tendinopathy where we're vertical, we actually want to come across the anterior of the knee. If the patient has quadriceps tendinitis, perhaps that presents up in this location superior to the joint, we place this electrode right over the center of where the pain presents. Same bony prominence, comfortable location for the dispersive pad. Touch the lateral aspect of the patella, come across the patellar tendon. If there's pain on the lateral side of the knee, an LCL sprain, bursitis, OA, or whatever might be causing pain on the lateral side, we place the small electrode directly over wherever the center of that pain site is. Now there's not enough room to be on the lateral side here because the electrodes can't be far enough apart, so we do the mirror image. We touch the medial side of the patella 3/4 of the way up, and we come across the patellar tendon this way. We stay off the VMO, the distal end of the quadriceps. Again, we don't want to hold this in tension, and this is a very comfortable location for treating anything on the lateral side of the knee. For IT band issues, iliotibial band pain, a lot of times that pain may present a little more proximal to the joint. So let's say this is where the IT band pain presents. Even though we're on the lateral side of the knee generally, now there's room to go back to the lateral side here of the patella and across the patellar tendon. So for IT band pain, this would be the ideal placement. Now, if the IT band pain presents in two locations, perhaps it presents not only in this location, but further up the IT band, then we can go back to using the B set, and we can place one electrode over one location of pain and the second electrode over the second location of pain, or it could be all the way up, higher up on the IT band, but this is going directly over wherever that second pain site might be. Okay, so that might be IT band where there's two locations of pain. For foot and ankle pain, the ideal bony prominence location to place the dispersive electrode is always going to be over the lateral malleolus. So as an example, this electrode will get placed typically in this location. But we're always going to place the pain site electrode first because we want to make sure we're over the pain site, and then we'll determine if there's enough spacing for this bony prominence location. So if you have a patient with an ankle sprain and the pain presents right here, ankle or foot sprain, we're going to place this electrode first, and then this bony prominence location will leave 1/2 inch of spacing, and this will come out over the malleolus and a little bit around the Achilles, if you could bend up just a little like that. So that would be a typical placement for, say, a foot or ankle sprain. If a patient had plantar fasciitis, this electrode is going to go right over the plantar fascia. I don't know if you can see that. So this is right over the pain site on the plantar fascia. This electrode is actually, we can place this a little bit further forward, so we're over the malleolus and just to the back of where the Achilles starts. And this is a comfortable place to take stimulation in the foot. If the pain is on the medial side of the foot, so we could, let's say the pain presents, whether it's more posterior or anterior, wherever this is, we're going to place this electrode over the pain site. Again, this gets placed on the lateral malleolus, on the opposite side of the ankle here. The reason we don't place this electrode over the medial malleolus is because this electrode can capture the tibial nerve running through here, and if we capture the tibial nerve, the patient can feel some stimulation from the tibial nerve under their arch to their big toe. Again, it can act like a distraction, and the patient may be limited in how high they go up because of this distraction that they're feeling here. So we never place this electrode on the medial malleolus for that reason. If there's pain and it's over where the tibial nerve passes through, and if we capture it, doesn't matter then if you feel the stimulation, because we want to treat over the pain site, and that's what's most important. For Achilles tendonitis, there's 3 ways to place the electrodes based on how the pain presents. If the pain only presents up higher on the Achilles tendon, then we're going to place 1 electrode right over the Achilles where the pain presents. And then instead of the lateral malleolus, we're actually going to go lateral part of the foot and around the calcaneus, so that we're capturing the insertion point of the Achilles with the second electrode. If the pain only presents at the insertion point of the Achilles tendon, then we're going to take this electrode, we're going to be right over the insertion point where the pain presents, and then this second electrode can run vertically up the Achilles. You want to make sure that if you're going to do any activity with your patient, that you put them in plantar flexion to make sure that these 2 electrodes don't touch each other. So if you're placing the electrodes and the tibia is at 90 degrees to the foot, make sure you're leaving more than 1 inch of spacing here, because when you go into plantar flexion, you can see how much closer they come together, and we don't want them to touch as the patient may be doing activity during the Biowave treatment. The third way to do an Achilles tendonitis placement is to use the B-set, and that's if the patient has pain both at the insertion point and further up the Achilles tendon. So this way we're getting kind of an equal treatment all along the Achilles. So we can place 1 electrode right over the insertion point if that's one of the locations where pain is presenting, and we can place the second electrode on the Achilles, further up the Achilles. Just again, make sure there's enough spacing just in case you are going to do any activity. We don't want the edges of these 2 electrodes to touch. So this is, we're treating this entire region of the Achilles tendon. When we treat over the Achilles tendon, use tape or cohesive wrap to help hold these electrodes in place. We're going over a tight contour here, and the electrodes may want to tend to peel back a little bit. So a little bit of compression with tape or wrap is good, because you're forcing the hydrogel into the pores of the skin. For 2 locations of pain on the foot or ankle, then we're going to use the B-set and cover those 2 locations of pain. So for example, if a patient has a high ankle sprain and perhaps the pain presents on the lateral or anterior part of the ankle, let's say that's 1 pain location, and perhaps there's medial side compression pain on the other side of the foot or ankle, we can place the 2 electrodes directly over the 2 locations of pain that present. They could be 2 locations of pain on the same side, on opposite sides, it doesn't matter. But if there are 2 locations of pain, then use the B-set electrodes to cover those 2 locations of pain. For neck pain, if there's a single location of pain, we're going to use the E-set electrodes. So the patient has to point to the center of where the pain is. Let's say this is the location where the pain presents. We can treat right over the spine. We can treat right up to the base of the skull. So the electrode can be right, it has to be over skin, so you have good adhesion. And then the bony prominence location for the second electrode is always going to be along the spine of scapula. So this front corner of the electrode can be just posterior to the AC joint, and then right along the spine of scapula here is where we want to run this electrode. So it's running at a little bit of an angle relative to how the shoulders run. And you can feel the spine of scapula right here. It's a very comfortable place to take stimulation. So the patient's only limited in how high they go up in intensity by what they tolerate over the single electrode directly over the pain site. For 2 locations of pain on the neck, the electrodes, there's ways to do that. So it depends how and where the pain presents. If the patient has bilateral neck pain and the pain presents here and here, or here and here, or here and here, we can place electrodes over those 2 locations. Okay, and this would be a typical bilateral neck pain placement. A lot of times patients, and a very common treatment we find is patients may have pain on one side of their neck, and they also have a secondary location of pain, or maybe the pain radiates down into the trapezius, and so we want to treat both where the pain originates or is in the neck, and also where the pain presents perhaps in the trapezius. This would be a very common neck pain type placement. If a patient had a cervical radiculopathy and it originates at, let's say, C3, and the most proximal location of pain is in the trapezius, this would also be for a cervical radiculopathy. If the first most proximal location the pain presents is closer to the shoulder, then we would place this electrode over where that pain presents in the shoulder. We would never place this second electrode distally, even if the patient feels pain radiating down through their elbow or down to their fingertips. We want to capture where the pain presents, again, the first location that the pain presents that's closest to the origin. If a patient has pain directly over one of the cervical discs, we can place one electrode directly over that location. The second electrode can go an inch below it, and so we can actually capture up to 3 or 4 cervical discs with this placement, and the hemispheres beneath these electrodes are intersecting internally, so we're really treating this one large region of pain. If there could be pain over multiple discs or pain just over a single disc. When we treat on the neck, many times electrodes don't stick well to the back of the neck, either because of fine hairs or oil or other types of skin conditions, and so we highly recommend taking tape and putting tape from one side all the way across to the other side here to help hold the electrodes in place. Even if this is just a static treatment and the patient is not moving, we always place tape over the electrodes when we're on the neck to help keep them in good contact with the skin. So we want the hydrogel getting through the pores of the skin so we have good electrical conduction, which will translate into better efficacy if we have good conduction through the skin. For shoulder pain, we're going to start with the anterior of the shoulder. So let's say the patient has a single location of pain. Again, we ask the patient, how and where does the pain present? Are there 2 locations of pain? Is there a single location of pain? So let's say in this case there's a single location of pain and the patient points here. Let's say it's a biceps tendonitis, or it could be a SLAP issue or a supraspinatus strain. They're all going to present in a similar location on the anterior of the shoulder. So let's say that's the location the pain's presenting. That's where we place that electrode. The bony prominence comfortable location for the second electrode is the same as it was for the neck. We want to be along the spine of scapula. So if you can rotate this way, this electrode, we're going to be just posterior to the AC joint, and the spine of scapula is right here. We're going to be right along the spine of scapula. Extremely comfortable place to take stimulation. The patient's getting a little bit of a treatment in through this location, but most of the sensation and most of the treatment is occurring in this hemisphere beneath the smaller electrode directly over the pain site. For an AC sprain, if the pain's going to present right over the AC joint, we're going to place this electrode right over that location that the pain presents, and this is a great treatment for AC sprains. Again, the bony prominence comfortable location for this electrode is right along the spine of scapula. This time we're not quite as far forward, we're more posterior along the spine of scapula because we're allowing for this spacing between these 2 electrodes. So this is still a comfortable location along the spine of scapula, and we're right over the pain site. For pain on the posterior of the shoulder, this side or that side?
This one would be better maybe for this angle.
So whether it's an infraspinatus issue or a posterior rotator cuff, we're going to place the single electrode directly over wherever the pain presents on the posterior of the shoulder. Again, we want to go spine of scapula, but now we want to still make sure we have enough spacing between the electrodes. So this might look more like this, and the spine of scapula is right about here, but we need to maintain enough spacing between the electrodes. Still a very comfortable location to take stimulation. Most of the sensation is felt in this hemisphere beneath the small 1.38 inch diameter electrode. For shoulder pain that originates in the trapezius, again, the patient points to the center of where the pain is. If it's a single location of pain, we place the one electrode in that location. Again, the bony prominence positioning for the dispersive pad is going to be just posterior to the AC joint, and the spine of, we're going to be right along the spine of scapula. So this might be a typical placement for a single location of trapezius pain. For shoulder pain, where there's two distinct locations of pain, for example, both the anterior of the shoulder and the posterior of the shoulder, or if pain occurs inside the joint and the patient cannot identify a single location of pain around the shoulder, then we use the B-set. So if someone has general pain inside the joint, I would have these two electrodes, one on the anterior, one on the posterior. I'd be up closer to the AC joint, so you're on a little bit bonier tissue. I'd be right over kind of the beginning of the spine of scapula. Maybe we're only an inch apart, and the electrodes are at an angle like this, and the electrical field is being driven down into the joint like that. That's for general pain inside the joint. But let's say the patient has two locations of pain. They have pain over the head of the biceps tendon, and they have pain somewhere on the posterior of the shoulder. Then you could use the B-set to treat like this, and we're treating a distinct location of pain here, and we're treating a distinct location of pain here. So you can use the B-set for treating pain if that's how it presents. If the patient says they have pain in their deltoid, but the diagnosis is really the pain is originating from the joint, it would be better to place the small pain site electrode closer to the joint on the bonier prominence toward the top of the shoulder. We don't like placing this directly over the deltoid because the deltoid is a muscle that will fatigue more easily as the patient goes to higher intensities versus other muscle locations. So if the pain originates in the deltoid and that's where the pain site is, then I would place the pain site electrode in this location. But if the pain is really in the joint and it's radiating down to the deltoid, you'd get a better treatment result treating up closer to the joint on the harder tissue. If you're over a bonier prominence, you can tolerate a greater signal strength. The patient can go up to a higher intensity. Again, the second electrode is along the spine of scapula, as with the other placements. And again, you can place some tape over the electrodes to help hold them in place particularly if your patient is going to be doing any type of active or passive range of motion during the treatment. If you're going to do active or passive range of motion on a shoulder, before you start the treatment, you want to make sure that these electrodes are not going to touch. So you want to range your patient through the entire range of motion and make sure that the edges of the electrodes don't touch. Once you've checked that, then the patient can go back to their neutral position, and you can hook up the electrodes and begin the treatment. For elbow pain, like a medial epicondylitis, a lateral epicondylitis, triceps tendonitis, we can treat those two different ways. If the pain is really point specific and the patient tends to be a little more sensitive to stimulation because the elbow is a more sensitive location to receive stimulation, we can use the E-set, and the single electrode is placed directly over the single pain site on the elbow. Again, we use the spine of scapula as the bony prominence location for the dispersive electrode. So, for example, for lateral epicondylitis, if the pain presents right in this location, we're going to place this electrode right over that one spot. And again, the bony prominence location is here. For medial epicondylitis, rotate a little bit more. For medial epicondylitis, if the pain presents, right, say in this location, then the small electrode is placed right over that location. Again, the bony prominence location for the other electrode is along the spine of scapula where we had it before. For triceps tendonitis, if the pain presents at the distal end of the triceps here, we're going to place this electrode right over the location that pain presents. So those are the three typical locations that we treat around the elbow. An alternative way for treating elbow pain is to use the B-set, the two same size electrodes, because we can hit the joint from two different angles, and feedback that we get from the field, for example, from Major League Baseball, where pitchers typically have medial epicondylitis from repetitive motion from throwing, as an example, we find we're getting better treatment results by treating not only the medial epicondyle, but placing the second electrode over the distal end of the triceps. So the typical placement for a medial epicondylitis would be we would place one electrode over where the pain presents on the medial epicondyle, and then the second electrode would be placed on the distal end of the triceps in this location, and this way, and you can see we have enough spacing between the two electrodes here, and this way we're hitting the elbow from two locations. So similarly, if we were going to treat lateral epicondylitis, we would place this one electrode over the lateral epicondyle, and the second electrode again would be in this location, posterior part of the elbow, distal end of the triceps. So we'd be hitting the elbow from these two locations, and we find that we get a better treatment result. So the preference for elbow pain would be to treat with the B-set on the elbow. This placement would also be for triceps tendonitis. So if the pain presented on the posterior of the elbow, then the first electrode's here. I would place the second electrode on the lateral side here, and again, you're hitting it from two sides. The only time I would go to the single electrode placement if a patient's more sensitive to stimulation and they don't want both electrodes on the elbow, but you will get a very focused treatment using the smaller electrode directly over that pain site location. So that's this is the alternative or maybe preferential method for treating elbow pain. When we do elbow treatments, we want to roll up a towel. It's typically available in a physical therapy clinic or athletic training setting because we want to keep the fingers in a comfortable position. If we're treating over the ulnar nerve, the electrical field captures the ulnar nerve. It wants to pull the pinky and ring finger in and wrist inwards. So this keeps the patient in a comfortable position. The patient can operate the intensity of the device with their other hand. For wrist, hand, and finger, we typically use the E-set because the region that we're treating is so small in volume, we're going to capture the entire wrist or finger or hand, wherever the location is that we're treating. So for pain on the wrist, that's on the anterior of the wrist, if this is where the pain presents, we're going to place this electrode directly over that location. We're typically going to place the electrodes in an opposing fashion. So the dispersive electrode is going to go across the posterior of the wrist, and you want to make sure there's enough spacing between the edges of the two electrodes here. And because again we're going over a tight contour, you want to take tape or cohesive wrap and wrap it around the electrode so we have good adhesion to the skin and conduction through the skin by pressing the hydrogel into the pores of the skin. If the patient has small diameter wrists and you're worried that the edges of the electrodes are going to be too close, then instead of being across the wrist, we can be partially on the back of the hand and run the electrode this way so we don't have a problem with the electrodes potentially touching. Stay off the forearms, the softer tissue there is not as comfortable to receive stimulation. If you are treating posterior of the wrist, then again, we're right over wherever the pain presents. We're going to place the dispersive pad across the anterior of the wrist. Again, we want to go directly across, use tape or wrap to hold this in place. If the wrist is too small, you can be partially up on the palm of the hand and along the wrist this way. Again, use tape to help hold these electrodes in place so that you have good adhesion, because we're going over not a completely flat location. For a TFCC issue, which may present on the side of the wrist, we can place this electrode right over that location. This second dispersive electrode can be in an opposing location. So again, you've got enough spacing here on this side, and you've got enough spacing on the other side of the wrist as well. If you were treating a UCL sprain at the base of the thumb, wherever the pain presents, we can be right over that location. We can be in an opposing location on the other side of the wrist when we're treating anywhere around the base of the thumb. If you're treating a phalangeal or interphalangeal joint, so for example, this is the location. Again, use tape to hold this electrode in place and snugly around the phalangeal or interphalangeal joint, and we can just go posterior of the wrist with the dispersive pad, and again use tape or wrap around this electrode as well. So those are the placements for wrist and hand pain. When we treat the wrist, hand, or finger, we want to roll up a towel that are typically available in a physical therapy location and have the patient hold the towel, and the purpose of this is to keep their fingers in a comfortable location. For example, if we were treating over the ulnar nerve, the stimulation wants to pull the pinky and ring finger in and pull the wrist this way, and we want to keep the hand in a comfortable position. So by doing this, we keep the hand in a comfortable position. If we were capturing the radial nerve, it may want to pull the middle finger up like this. So again, the patient holds the towel to keep their fingers in a comfortable position. The patient can operate the device with their other hand.